So happy Black and Cancer Week 2021, and welcome to Evading the Myths 2.0. Today we have the Onc Docs coming back to give us the tea on all cancer and COVID-19. And just for some brief introductions, Dr. Onye Balogun is a radiation oncologist specializing in breast and gynecologic cancers. She is a graduate of Harvard University and Yale University School of Medicine. Dr. Balogun initiated her residency training at the University of Chicago and completed her final year at New York University. She has conducted and published breast cancer research and novel therapeutics for triple-negative breast cancer, and her global health activities focus on improving the delivery of radiation therapy in low and middle-income countries. And next, Dr. Folu Balogun is a medical oncologist specializing in gastrointestinal tumors, including pancreatic, hepatic, and biliary tumors. He completed his undergraduate degree at the University of Maryland, Baltimore County, then completed his MD PhD at the University of Chicago with a dissertation on DNA repair. At New York University, he trained in internal medicine, then completed his hematology oncology fellowship. Today, the Onc Docs will be giving us an amazing presentation. And we ask that if you have questions, drop them in the chat, and we'll get to all the questions after the presentation. But I would love to welcome the Onc Docs on.
Thank you so much for having us.
Thank you very much. It's an honor to join again.
We're really excited to kind of get the conversation going again. And please feel free to go ahead and share your screen and start sharing your slides.
All right, do you see my screen?
Yes, perfect.
Good. All right, so today we'll be talking about cancer, and we'll also be touching on COVID-19 and Evading Myths 2.0. So as we all know, Black and Cancer Week, and we're glad and excited to join here. So just going back a little bit to the basics, what is cancer? Cancer, as I like to describe it, is pretty much when normal cells go rogue. There is a method to which cells replicate, they grow, they duplicate, and then they have a complete life cycle whereby they die. And during this time, they're also productive members, essentially, of society. So I'll describe a lot of this the way I do. I tend to discuss it with my patients. But with cancer cells and with normal cells, something that does happen is they do undergo DNA damage. So we'll talk a little bit more about this, but when that occurs, it leads to, it typically gets repaired, but if this falls through the cracks, can lead to cancer cells, which are essentially immortal. And not only are they immortal, but they don't seem to contribute to society. They just grow, and don't do the jobs that they're supposed to do to help or to better their body. So the DNA that we talk about, I like to describe as the blueprint, which we're all familiar with, the blueprint of our cells, tells our cells and our body what to do, what to become, and how to behave. They're constantly exposed to damaging agents in our environment, and even within us. Our body does have multiple levels at which it fixes this. And when the errors fall through the cracks, the body also does have a way of apoptosis, which is essentially suicide of the cell. In some cases, yes?
Really quick, I don't think your slides are advancing, if you are advancing them.
Oh, okay. Is it advancing now?
Now it is, yes.
Okay, all right, thank you. So when the damage does occur and the cells actually evade even all the way up to apoptosis, it could lead to cancer. And with cancer, we do have cancers that occur all over the body. When we look at the statistics, some of the most common cancers, both in the States, and a lot of these also mirror globally, prostate and breast in men and women. Lung is, when you look at both of them combined, lung is the most common cancer, and then colorectal is the next one, with several of the other common cancers listed here. Now, when we come to estimated deaths that we get from cancers, the first couple ones are still similar in terms of both the incidence, but we also do find out that some of the less common cancers may actually become much more have a much higher mortality rate. So pancreas being an example of one of those. I am biased because I do treat pancreas. I always point it out. It's about number 10 in terms of incidence, but comes up to number 4. Breasts, colon, lung still remain pretty high, both in terms of incidence and mortality rates. Now, our first fact or myth for the day. Cancer only develops in people who have a family history of cancer. The fact about that is most people, or the truth about it, because this is a myth, is that most people who are diagnosed with cancer have no known family history. While family history is very important in terms of both surveillance and preventing cancer or catching it early, most cases are found in people who have no history, and that's why things like surveillance, there's a standard surveillance that occurs for colorectal cancer, breast cancer, very important. Now we'll talk a little bit more about some of the more specific cancers, starting with breast cancer, and Onya will pick up from here.
Thank you. So, as Folu mentioned, even though the majority of cancers are not hereditary, about 5 to 10% are hereditary. So what does, what leave for the rest of us, who may not have any family history of cancer, what can we do ourselves? So we wanted to focus, we clearly can't touch on all the cancers. There are just far too many, but we thought we would touch on some of the ones that are the most common, being breast, lung, and colorectal cancer, to talk about how can we maybe empower ourselves to detect cancers early, what can we do to decrease our risk. So with that in mind, with breast cancer, as we know, it's the most common cancer among women in the United States, with an estimated 282,000 cases that will happen this year. And risk factors for breast cancer include age. So just like many other cancers, where as you get older, there's more opportunity for errors to arise as your DNA is being copied and the genetic material is being duplicated. That can give rise to cancer. So age, like many cancers, is the number one risk factor for developing breast cancer. Also, if you have a personal history of breast cancer or non-cancerous breast disease, you have a higher risk of developing breast cancer. So the non-cancerous breast disease that you might hear of is something called atypical ductal hyperplasia. So if someone has ever mentioned that to you or said ADH, that is not yet cancer, but it's something that's been known to be associated with future development. So you'd want to talk to your doctor about what kind of surveillance you should do given that kind of history in you. Also, as we know, family history of breast cancer, especially when we notice that there is a family member who's had cancer at 50 years of age or less, or if there's male breast cancer. And people always come to me and they say men have breast cancer. Definitely, absolutely. Matthew Knowles, as many of you may know, well, he's Beyonce's father, and I love all things Beyonce. So that's just a disclaimer. But Matthew Knowles had breast cancer. So when we see something like that, we want to make sure to alert that individual as well as the rest of the family that we may need to do additional testing to see if they're part of that, 5 to people or families where there is an inherited predisposition to developing cancer. A history of radiation therapy to the breast or chest also increases your risk. So the caveat to this is that the risk isn't as high if you receive radiation to the chest after you're 30 years old. It's before you're 30 years old that has the greatest risk of developing a cancer down the line. But it's just something to keep in mind if someone comes to you mentioning that sort of thing. obesity. We know there's an obesity epidemic in our country, and it's so important. This is something that we can control, right? You can be wary of how much exercise you get. You can be also cognizant about what kinds of foods you're eating. And the reason why obesity is tied to breast cancer is because fat, right? Fat can be a source of estrogen. And there are some breast cancer subtypes, some types of breast cancer that like to use estrogen to grow. So the more, fat you have in your body, you're making more estrogen, then you're possibly stimulating, potential breast cancer to develop. So very important to think about that. Alcohol. This is where it gets, touchy, because nothing wrong with a drink once in a while. And I think we always counsel our patients that, just because if you say you drink once a week, but it's like a, 50-liter bottle, which I don't think anyone is doing, that's still too much. But we always say everything in moderation. So alcohol, if you're having more than two drinks per week or so, then let's say 2 glasses of wine or the equivalent, 2 to 3, that I think is a significant risk for breast cancer. Next slide, please. So when it comes to lung cancer is, as we mentioned, the second most common cancer in the United States. It's the number one cause of deaths among men and women. But fortunately, the number of new cases are declining. In terms of risk factors, number one, smoking cigarettes, right? So we know that if you smoke cigarettes, it ratchets up your risk. It increases your risk more than 20 times. So I always think that one of the most powerful things we can do is to get our loved ones to stop smoking. And it's not easy, but what we know is that the people who make a plan, right, they choose a date that stop smoking and who keep trying, even if you don't get it the first time, if you keep trying, those are the people who are most likely to stop smoking. Similarly, secondhand smoke is also a risk factor. Air pollution. There was recently, I think it came out from maybe the World Health Organization, a report showing that pollution is really becoming one of the most important factors contributing to cancer. So it's up to our government to really do their part to try and decrease the population's risk for cancer. Radon gas, and of course, so asbestos used to be a serious issue in housing. It can cause several different forms of cancer, but one is called mesothelioma, like along the lining of the lungs. So we want to make sure that with lung cancer, we do all in our power to decrease our risk for that. And I think the most important one, if you can only remember one thing tonight, would be smoking, to stop smoking. Next slide, please. When it comes to colorectal cancer, that's the third most common cancer in the United States. And unfortunately, we do see the number rising, especially amongst the younger population these days. And we'll understand why, because it seems to be a global phenomenon. Some of the risk factors for colorectal cancer include a family colorectal cancer. So there's certain changes in your DNA that can be passed down from person to person. And these really increase your risk for colon cancer. So some of the things you might hear of are something called FAP, where people form a lot of polyps in their colon. There's also something called Lynch syndrome, which can also be detected in your DNA if we test for it. So if you hear of those things, or you see a lot of family members who have colon cancer, then that might be something you want to investigate. If you have a personal history of polyps, that can also include colorectal cancer. A history of inflammatory bowel disease, ulcerative colitis is one of the diseases that can increase your risk for colon cancer, as well as Crohn's. So those are two important diseases that might increase your risk of colon cancer, and we have to watch you much closer if that's the case. Obesity also plays a role in colon cancer, as well as diets that are high in red or processed meats. So I'm going to call Folu out here, but he loves his red meat, but we have to do it in moderation because colorectal cancer, as well as other things, are a risk. Smoking, again, plays a role in colon cancer, type 2 diabetes, and also alcohol. So as we said, everything in moderation. You don't want to, I'm not going to sit here and lie to you. Since I've called Folu out, I will also call myself out. I love ice cream. I could eat it probably every day, but I don't, because everything in moderation, and you want to try and promote a healthy lifestyle as much as possible. Okay, so next slide, please. So this will bring us to our second question, which is, if I exercise and avoid smoking and alcohol, right, you will never develop cancer. So we wish that was the case, but unfortunately, the truth of it is that those are behaviors that will decrease your risk of developing cancer. However, they're not 100% guarantees. I unfortunately know people who were, doing Ironman triathlons that ended up developing cancer. So we still don't understand why it's not enough to exercise, avoid smoking, and, have alcohol in moderation or not at all. Why those aren't enough to just prevent you from having cancer, but those will decrease your risk. And then we want to talk about other things that can help you to decrease your risk of developing cancer, as well as signs and symptoms, so that you can catch it early. So next slide, please. When it comes to breast cancer, of course, it's a little bit controversial, the self-exam. There was actually a recommendation that women not do self-exams anymore because there was no evidence that it really helped. The physicians that I know still recommend a breast self-exam, and I honestly don't think it will hurt. The only scenario in which I think a breast self-exam can hurt is if you tend to be an anxious person, and if everything you feel will set you off, then by all means don't do it. But if you are a woman who is, I even, tell women as early as like their 30s, young women, you can start checking, choose a time of the month, and regularly, and stick to that. So, okay, choose a time. I see we're getting some questions. So hopefully we'll wrap up in the next 15 minutes and address those questions. But what you want to do is, if you are a menstruating woman, choose about a week after your period, not during your period, because there are changes in the breast and can also be tender and painful. But after your period, about a week later, check your breasts. And, there are tons of pamphlets out there. We're happy to share them. They're on the Susan Komen website or the American Cancer Society website about how to check your breasts. And then you also want to make sure that you go in annually to see your physician for a clinical breast exam, which is also has been controversial, but I personally do not think it hurts. Mammograms are recommended as well, because they've been shown to decrease the risk of late stage breast cancer. Mammograms actually turned around the trajectory of breast cancer because we were able to catch things much earlier. So there have been a lot of controversy surrounding the age at which people should get mammograms. And for a long time, it was 40 years old, start at the age of 40. But you may hear about the United States Prevention Services Task Force that said that women should get it starting at the age of 50, and that they could get it every 2 years rather than once a year. And I think that you can't, I personally don't like that approach, because we meet who a lot of young women who come to me in their 30s. I've seen a number of 30-year-old women with breast cancer, especially because we know that the more aggressive subtypes of breast cancer, you may have heard of triple negative breast cancer, tend to occur in young Hispanic and African American women. And if they're waiting, till 50, how many more lives are we going to lose? So myself and many of my colleagues and many other organizations, American Cancer Society, the Society of Breast Surgeons, do recommend still starting at 40. The caveat is that if you have a family history of breast cancer, you want to start mammograms, or ultrasound, or MRI, about 10 years before it was detected in the youngest person in your family. So let's say, your mother had breast cancer detected at the age of, 45. You want to start your screening at 35. Also, other ways to prevent breast cancer are if you know you have a family history and they do genetic testing and you have a gene called BRCA that is mutated, a certain form of it, then in that instance, you may consider having a mastectomy. And or at the right age, you may, if you're done with childbearing, you may also consider an oophorectomy, taking out your ovaries. People have also done some studies looking at drugs called aromatase inhibitors, taking them for preventive purposes. Exercise, of course, and limiting your alcohol consumption can also help. So next slide, please. So what are some of the common symptoms? You may notice a lump. That's one of the most common symptoms. If you see indentation or puckering of your breast where there wasn't any before, that's a sign you should go and get it checked out. If there's nipple discharge, redness, or swelling of the breast, those are also changes that should alert you that there might be something going on. And of course, these are the tests that they will do. I just wanted to give you a sense of that. When it comes to lung cancer, we want people, of course, to abstain from smoking. We're still doing research on e-cigarettes to find out what's their risk. We don't think that they're completely benign and harmless, but we don't yet know exactly what their risk is. We've studied cigarette smoke much more. You also want to make sure that you minimize your exposure to secondhand smoke. And CT scans are recommended annually in people who are current or former smokers who had a 30-pack year history or more. And so those are several of the things you can do to, try and maybe not necessarily, to decrease of lung cancer, but the CT scans will hopefully help detect it early. Next slide, please. And I think I just wanted to bring home the point again that it's not just lung cancer that smoking will affect. It also increases your risk for cervical cancer, colorectal cancer, ovarian cancer. So there are many benefits to be reaped from stopping smoking. Next slide, please. And of course, common symptoms of lung cancer include coughing. You may or may not see blood, but if you have a new cough or a worsened cough, have that checked out by your medical professional. Weight loss, chest pain, hoarseness can also be an cancer, and being short of breath. And in order to work it up, they will probably get a chest x-ray or a CT scan of the chest. And, to show you those procedures that they might do, shown in the images here on the right. So you can move on to the next slide, please. When it comes to colon cancer, colonoscopy actually, for a long time, we were saying that it should begin at age 50. They've now moved up the age for colon cancer. So I know a lot of people are hesitant to do it, but really it's something that really has the power to revolutionize and to detect things very early and to just change the trajectory of your disease. So much easier to remove a polyp that a doctor sees than to go through the treatment needed for, an advanced colon cancer. So I recommend everyone just, when you hit it, think of it as a celebration when you hit that age and go for the colonoscopy. Of course, moderate consumption of red and processed meats, increasing your fruits and vegetables, eating more fiber, getting physical exercise because obesity increases your risk of colon cancer, and again, stopping smoking. Next slide, please. And common symptoms. If you notice rectal bleeding, please come into your doctor. If you have a history of hemorrhoids, you may know what that's like, fine. But if you don't and you notice rectal bleeding, come into your doctor. And one thing I want to say is younger people, we see colon cancer, like I mentioned before, is becoming more and more common. Frequently, young people will go in, they'll be in their 40s, they're noticing blood in their stool. And, the doctor isn't thinking that colon cancer is on the differential, but advocate for yourself. Insist on it. Ask, let me get that colonoscopy, because it could very well be a make or break kind of situation. And I've heard too many stories. So just, physicians have to be on the lookout. PAs, whoever is providing healthcare has to be on the lookout, and also advocate for yourself. Even if you're young and the colon cancer is low down on the differential, just let them work it up. If you've noticed a change in your stools as well, let's say your stools are a certain thickness, but you notice that they're thinner, that should also be a warning sign that you need to check out what's going on. And of course, weight loss. So some of the things that they might do if you go in with these issues to your healthcare provider is a rectal exam in the clinic. They may also want to sample the blood, check if there's blood in your stools. And, we've come so far that we can even test that. They might perform some imaging of the abdomen and pelvis. And of course, if they do a colonoscopy, they'll want to get sample of any abnormal tissue that they see. Next slide, please.
So just to highlight before we move on to that side, something that only has on here with the FIT test, people do get reluctant for the colonoscopy. Fortunately, some of these other tests are very effective too. Now, that does not mean you may not need the colonoscopy, but the FIT test, for example, can be done in the privacy of your home. Get a stool sample, put it there, and mail it back. And it's something that's done annually, and it's one of the first line recommendations too for screening. So if we're hesitant about the colonoscopy up front, that doesn't mean we shouldn't still talk to our doctors about options.
Great point. Excellent point. All right, next slide, please. So now we come to the COVID-19 section of our talk, and I will hand it over to Folu.
So this, let's see. All right, so the myth, sorry, it's moving slowly through. So the question is, or the fact of the myth, we're out to another one. If for someone who has cancer, if I have cancer, I have a higher risk of getting sick with COVID-19. Maybe. So for that, maybe we'll just leave it and let it sink in for a little bit. When we talk more about COVID, we want you to think about what that is in terms of what the maybe is, and then we'll talk about how COVID intersects with cancer in a few minutes, and I'll ask you the questions again. Another one is, Another myth or fact question relating to what Oyin has been talking about is all cancer is basically treated the same way, and your hair will fall out. Oyin, can you tell us a little bit more about this?
So I thought this was so important for us to address. And I love that picture we have back there because one size doesn't fit all. We all know someone who, has been going through cancer treatments. And of course, people will tell them, oh, this was the experience that my relative or my friend or someone I know from my polo club, had. But it's so important to know that there are so many different ways to treat different cancers. So just to run through these, and in the interest of time, I'm going to just kind of talk about the different classes of ways that people can be treated. Let's take breast cancer, for instance, right? So for women who have breast cancer, frequently surgery is a part of the equation. And surgery is not just surgery. It's not one size fits all. You may have a lumpectomy, meaning that they just take out part of your breast. You may have a mastectomy, meaning that they take the entire breast, they remove the entire breast. You may also choose to have reconstruction, where they collaborate, the breast surgeon collaborates with a plastic surgeon to create a new breast for you, either out of muscle tissue or through using implants. So there's so many different variations for surgery. There's also the possibility that you might need some radiation therapy, which I like to describe as more powerful X-rays. And what those more powerful X-rays do is usually when it comes to cancer, they are cleaning up or killing off any less than microscopic cancer cells that are just lying around in wait, right? They're killing off anything that we can't see with our eyes or remove using surgery. So you might have radiation and you might not. You may also have something called rather anti-hormonal therapy. You may remember earlier that I said some breast cancers using estrogen. And so there are some drugs that suppress the level of estrogen in your body, and your doctor might think that that's appropriate for you. There are some breast cancers that do not thrive using estrogen. So we have to make sure that we don't give you hormonal therapy because it's not going to do anything for you. So when people are discussing, treatments, keep these things in mind that even within surgery, there are different types of surgery. Even with hormonal therapy, there's so many different drugs. So it's not one size fits all. When it comes to chemotherapy, there are certain types of chemotherapy. And when I say chemotherapy, that's usually medication that is supposed to go through your entire body, right? In order to kill off anywhere that cancer might be hiding. So frequently it's given through an IV, but there are forms of chemotherapy that you can take as a pill. So different ways to do things. If someone got an IV and you're getting pills, it doesn't necessarily mean that you're not getting the right cancer treatment. It just might be that this is what's suitable for you. There are also classes of drugs called targeted therapy, meaning that there are specific genes or there are specific changes in that cancer that make it more likely to respond to a certain drug. And so we have so many new targeted therapies, and you might be a candidate for that, but your friend's grandmother may not be, even though they both had lung or breast or colorectal cancer. And then you may also have heard about something called immunotherapy, which is a way for us to kind of ramp up the immune system to fight your cancer. So there are certain people who qualify for immunotherapy, and there's some who don't. So the main point is just that you're not going to have the same exact treatment as someone else, most likely, and that not everything is going to make your hair fall out. I'm a radiation oncologist, and that's one of the top questions that people ask me, because it's understandable. It's something that is very it's a big change in your appearance. It's a big change in how you see yourself. So I can understand the concern, but your hair is not necessarily going to fall out. And we even have treatments that we can give you while you're receiving chemotherapy to decrease the risk of your hair falling out if you happen to be getting one of those drugs. So I'll skip the lung cancer and the colorectal cancer slides for this because they're basically reiterating similar themes, and we'll move on to the next slide. So there is no hope for stage 4 cancer. So you may know that cancer has different stages, right? Stage 1 means usually that it's localized to where it began. 2, 3, with 4 meaning that it has spread from where it began to other sites of the body. And sometimes think, oh, there's no hope for stage 4, but that's not true. As you can see from this graph, from a report from the American Cancer Society, the risk of death due to cancers is falling. Here, lung cancer is falling. The risk of death due to colon cancer or so many other tumors is falling. And specifically, I focus on breast and gynecologic cancers. Next slide, please. I wanted to highlight that there's hope. Look at this information. In 1990s, about 20% of young women would survive 5 years with stage 4 cancer. Now we've doubled that. So yes, we still have a long way to go. We're not even ready to pat ourselves on the back yet when it comes to advances in cancer, but the main idea is that there's still hope. We're slowly chipping away at this question of cancer. And even if someone's diagnosed with stage 4, we still have a lot of options for them. So we'll move on to the next slide.
So we're back to our intersection of COVID and cancer, because we would have to there's something that with the pandemic going on that affects pretty much everything. Just a quick reminder of some of the factors that were most consistently linked with increasing the risk of having severe disease, and higher risk of dying from COVID. And these were male sex, being older age, history of smoking, obesity, hypertension, cardiovascular disease, and diabetes. Some of these also overlap or mirror the risks associated with cancer. Now, where does cancer actually fit in this? And that was the fact or mix that we had asked you earlier on. And we're coming back again to that in a different format. So if you have cancer, the question is, if you have cancer, do you have a higher chance of getting sick from COVID? Previously we had said like maybe, and now it's more of it depends, pretty much the same thing, but there is some intricacy to it. So we know that from the studies and from looking at people, different numbers of people who had cancer and also had COVID, people who had certain types of cancers, mostly blood cancers, tended to be at a higher risk of getting sick from COVID and also having a higher risk of dying from COVID. Those with solid cancers, so a lot of what we've been talking about, the breast cancer, the lung cancer, the pancreatic cancer, when they're going on receiving chemotherapy, that's when they have a higher risk of getting sicker and dying from COVID. So just having those cancers or a history of them may not necessarily increase their risk, but if they're actively undergoing chemotherapy, that gives them a higher risk. Now, those with blood cancers, it makes sense because your blood cancers are your blood cells that protect you. So if they're suffering from cancer, then they're not in a good place to protect you. And also chemotherapy suppresses your immune system. So that also makes sense as to why these people have a higher risk. These groups of people have a higher risk of getting sick, more severe illness from COVID. Should I get the COVID-19 vaccine? The answer is an absolute yes. The reason being, it decreases the risk of hospitalization and death. And this is across the board for everyone, pretty much. While it may not, while people who have the vaccine, as we know, can still get sick, but they usually have a mild disease or mild symptoms of the disease and much less risk of hospitalization and significantly much less risk of death from COVID-19. Now, when we talk specifically about cancer patients, those with cancer, do they develop? One of the factor myth questions is, when someone has cancer, do they develop sufficient immunity to SARS-CoV-2 when given the vaccine? I just mentioned how cancer is immunosuppressive. So if your immune system is suppressed and you get the vaccine to boost that immune system, is it worth it at all? It's a very good point, a very good question. And the answer really is that cancer patients, including those who are undergoing chemotherapy, they do develop immunity in response to the vaccine. So they get the vaccine and they respond and they become better able to protect themselves against COVID. However, it's not quite as robust as you would see in people who don't have cancer or people who are not undergoing chemotherapy. So there is some validity to that. And that also is part of the reason, it's a big part of the reason why people who are actively cancer patients, certain groups of cancer patients were under the group that were recommended to get booster shots early on, because we did see that in some of the studies, when they looked at the amount of antibodies created, there was a much sharper decline in cancer patients who were getting treated with chemotherapy, similar to what we saw in immunosuppressed individuals. So the booster shot would make a lot of sense for them. Now, COVID-19 can cause a lot of long-term side effects. There's a lot of talk about, or a lot of worry about, well, there are certain things that we don't know about, say the vaccine or other things like that. But there's also a lot we don't know about COVID-19, and there's a lot we've learned about it in terms of potential long-term side effects. It has a propensity to severely attack or to focus on attacking the vessels, which supply blood to all over our body. So it can really affect anywhere. You have risks and documented risk cases of increased long-term heart problems, worsening kidney functions, surely increased blood clots, lung damage, and what's generally known as brain fog or nerve problems. There's still a lot of work going into tease these better apart, but we're seeing it as long-term side effects of having the COVID-19. And with that, we'd like to thank you all for your attention and open the floor up for questions. I know some of them have come up in the chat already, and we can start with those.
Perfect. So what I'll do is I'll go ahead and go through some of the questions. I think one of the most recent questions was, if I can find it, is it true that there is regional differences in survival rate?
So I'm guessing that the regional differences are like looking at different states. So that's how I'll interpret it. So absolutely, there are certainly differences. There's certainly differences in survival in different states. So some of that is tied to, number one, the risk factors, right, that you might see in certain states. So for instance, states where there's more smoking, right, you have higher rates of smoking, you might see more lung cancer or the other cancers that we talked about, cervical, colon, it affects so many diseases. So that's one. Obesity, right? We know, I don't know what's the fittest state off the top of my mind. I wonder if it's California, but obesity in states where you have higher rates of obesity, that can certainly impact the incidence of cancer as well as your ability, the survival. Because we know people who are more fit going into treatment tend to do better. So there are absolutely regional differences. And that also makes me think about inequities, right? The past year has brought to light so many inequities. The social justice reckoning that we've had has been reflected in our health system. We saw that people who are non-Hispanic, not whites had better outcomes with COVID than those of Hispanic ethnicity or, other races, Black individuals especially. So unfortunately, we see that not just with COVID, we see it with cancer, breast cancer, just colorectal cancer. Black men are more likely to die. And a lot of this is tied to what people call, social determinants of health, right? So your literacy, if you're able to read, are you able to advocate for yourself, look up information, understand what your doctor is talking to you about, where you live, what groceries are you able to buy, what groceries are you able to afford as a result of your socioeconomic level. So unfortunately, we are not yet there where everyone is guaranteed a great outcome if they're diagnosed with cancer. But I'm hoping, and Folu and I are working through our research, through our clinical work, to create a more equitable, more just system where what we have to worry about is what kind of cancer do you have? What are the best treatments? Not all these other factors that also affect your outcomes.
Great. Thank you for that. I think we have two other questions, but it was surrounding breast cancer when you were talking about radiation. One question was, when would someone receive radiation to the breast if they didn't have breast cancer?
Great question. If someone needed radiation for some other kind of tumor, so for instance, the most common one that comes to mind is Hodgkin's lymphoma, right? There were a lot of young women who would develop Hodgkin's lymphoma in the center of their chest, and they would need radiation to that region. And we didn't have the sophisticated technology back then that we do now that can really, focus the radiation in on specific areas. Even now, if you need radiation to the chest area, depending on where the tumor is, you may still get some radiation to the breast. So that's where it might come in, that you might get radiation dose to the even though they're not targeting your breast. There's some radiation dose that kind of will still hit that area. It's lower than what's going to your target, but it's increase your risk of having changes in the cells that can lead to cancer.
Great, thanks. And just to switch subjects, regarding colorectal cancer screening, I know you mentioned the age was 45, but is that across all sexes? What about African Americans who are diagnosed younger? Should they be tested earlier, or is 45 the age that everyone should abide by?
So 45, it's a very good question. 45 is the range for average risk. Now, what is defined as average risk? Essentially, if you have no history of cancer in the family, and if there's anyone in the family who has had cancer, then that number may change. And that's something where you need to talk to your doctor and to look at the numbers to tell you when it should be. One example is if there's a family member who got diagnosed at the age of 45, then you have to start your colonoscopy 10 years before. So it becomes 35 for that person, for you, instead of 45. And also risk of some other mutational germline or genetic mutations that may run in the family, and also some chronic diseases, like if you have Crohn's in the GI system, so the colon, like Crohn's disease, ulcerative colitis, and if there's a history of family members or even the person getting higher numbers of polyps, that also changes the age at which you're screened. But if 45 is for average risk. For anything else, if there's any history of any disease in the GI tract, the colon, or any history of family cancer in the family, definitely talk to your doctor so they can modify that or make that more specific to you.
Great, thank you. I think we can make this our last question. I don't see any more questions coming into the chat. But regarding vaping, and lung cancer. Should we watch out for this for vaping pens that just has tobacco, or what about those vaping pens that have THC? Or is it all e-cigarettes in general?
So I think the problem with it is there's so much variability. A big concern is the chemicals that assist in the vaporization of the actual drug or the actual stimulant or whatnot that's in there. Those ones and what they can cause, it's not tightly regulated, and there's a variety of it. So some of them are carcinogens, and because of that uncertainty of what is what in there, there's the general idea that e-cigarettes as a whole pose a risk.
All right, thank you so much. And we'll end on that note. We want to thank the Docs once again for giving us a great session. Thank you for everyone who put in questions. I think it was really informative, and I think we had a fruitful discussion about all things cancer and COVID-19. If you want to review this session, it will be recorded. Well, it is recorded, and we'll upload it on YouTube once the week is over. And just to put a shameless plug, tomorrow we'll be having a session about post-diagnosis. The session is titled, "I've been diagnosed with cancer, so what's next?" So this conversation will be about how to support family members, how to support friends who may have been diagnosed with cancer, and how do you move post that diagnosis with support. And so I just want to say thank you, everyone, again, and good evening to everyone on the UK side, and good evening to everyone that's in the States.
Thank you. It was an honor, and
thank you.
This is great. This Black and Cancer Week is always great. I'm excited to be a part again.